Okay, so welcome to BTSS E-Forum. And today we are going to embark on the first of our three-part series on side effects and brain injuries. As a brain tumor patient myself and a caregiver of my mom who had brain cancer, this is obviously a very concerning topic for all of us who have to consider treatments. But we are concerned that sometimes the treatment could actually be more challenging or perhaps even far worse than the disease in itself. Now, is that possible? So I think, therefore, it is time that we take a good look into this matter by addressing these questions, firstly, with doctors who are involved in treating us, and secondly, in the part two series, we'll be talking about what if you are trying to cope with one of the side effects of brain injuries, or maybe a range of them that we would be talking about. And finally, we want to address the real practical issues of having to live with side effect and brain injury for the rest of our lives as patients. So I'd like to move on to explain with my next slide, which doesn't seem to be responding. So, okay, I will have to stop the slide share and try again. Okay. Right. So moving on to the next slide. Okay, so I would like to share some guidelines for the e-forum. It is very heartening to have such a big turnout and to ensure that everything is organized and at the same time comfortable for you and our presenters. I would like to share the guidelines. So throughout the forum, the speakers, Dr. David Low and myself, as part of the panel, will have our videos on, while the rest of you will have your videos off. Then at the same time, all speakers, including myself, and all of you in the audience will be on mute, and unless we are presenting or speaking. Then at the same time, sometimes speakers, when you have a point that you would like to respond to, please let me know as well, so that I would be able to invite you into the discussion. So as for participants, I would like you to be on mute and your video off. And at the same time, as you have a thought or a question that you want to ask, please feel free to type it into the chat, which is located at the bottom of your screen where you see the Zoom toolbar. You just move to one that's called chat and it works like the messenger. Just type in your question. And at the right time, I would actually convey your questions to the right doctor or the panel. Okay. And as I have already said earlier, the e-forum will be recorded and will be eventually shared on BTSS social media platforms. This is to allow our friends who are not able to join us today to also benefit from today's discussion. And finally, I like to remind that, as usual, this forum is meant for sharing purposes, and it is not possible for our doctors to give you advice on your treatments. So whatever that you hear today, you still have to talk to your physicians about it to ensure that you get the right advice that's specific to your individual condition. So let's look at the poster that you probably have received to gain clarity about what we are doing. So the blue part 1 is what we are talking about today. So we're going to find out, how in neurosurgery, in chemotherapy, and in radiotherapy, the doctors strive to protect you from having these kinds of possible side effects. And then again, they would be sharing about the potential side effects that they are well aware of from, their statistics, from the past, their experiences. They are very well aware of certain side effects that can potentially be experienced by our patients, but they have also precautionary measures that perhaps it will be comforting for us to know that they would be very committed to do. Then at the same time, there may be questions that you want to ask, feel free, but remember it's not a consultation session. Okay, so the three doctors speaking today would be Dr. Sharon Low, and she's a consultant and the head of neurological services in KK Women's and Children's Hospital. And we would have the next speaker, Dr. Lin Xuling, and she's a consultant with the neuro-oncology and an eye department. And from NUH, we have Dr. Bala Murugan, and he is a consultant in the radio-oncology department with the NUCI, which is the National University Cancer Institute of Singapore. They are all very, very experienced consultants, and we are certainly privileged to have them sparing their Saturday afternoon to share with us. So this is the agenda. This is what it will look like. So Dr. Sharon Low will present first, and any questions relating to neurosurgery, okay, we will allow about 5 minutes to handle it. And then after that, we move on to Dr. Lin Xuling. And then again, questions specific to her talk on chemotherapy. And finally, Dr. Bala Murugan. And then questions related to radiotherapy. And after that, we will have, you can ask anything you want that's relevant to our panel as the closing, okay?
Right, thanks. Let me try this share screen. All right.
Okay. Yeah, we can see it good.
All right, thanks. I'd like to thank BTSS, Melissa and David for giving me the opportunity to talk today on this Saturday afternoon. So this is a very broad topic, and I'm not sure if I'm able to cover every single detail in the next 10 minutes or so, but I'll try my best. So today I'll just try to explain to the audience and the people around today to some side effects and possible brain injuries that may be encountered from a neurosurgical perspective. So this is an outline of my talk. So I'm just going to bring people through a background of how brain tumor surgery and the sort of journey that it entails, and perhaps some expectations people, the doctors, patients, and their caregivers may have on the ground, and also to end off with some general information about the topic today. So brain tumor surgery. So a typical journey doesn't really matter where the brain tumor is located. We all start off with a diagnosis, so that happens when we consult our doctors, myself included. And once we decided that the aim of this journey to start off is the surgery, we'll proceed to do some preoperative preparation. That includes some blood tests, could be ECG, chest X-ray, speaking to the anesthetist, or even the hormone doctors, the endocrinologists, to prepare yourselves. And of course, during the surgery, that's where myself and my team would come in. And I've broken down surgery into three parts after the surgery. So there is the early part of the surgery immediately, where we still see you in the ward, where you have a dressing after the craniotomy or the surgery is done. Sometimes if the surgery is done through the nose, you may have a nose pack. So it really depends on where exactly the tumor is located. So after this early phase is over, we would expect you to either go home, or if we feel that you can benefit from a bit of neurorehabilitation, we may refer you to our physiotherapist or our neurorehab doctors for some exercises to optimize your recovery. And after that, you do go home, and in the long term, we still need to see you on long-term follow-up. So that's to follow up with some scans and we will continue to see you definitely for a long time after that. So this is just a sort of a typical journey. I mean, it could vary from person to person, but essentially where the doctors sort of come in is during the surgery and after the surgery. So this is a small project that I set up for my kids at KK Hospital. So I usually show them some of the examples of the wound sites that might happen after surgery. So essentially is to let the patient and the parents know where the wound incision may be located, so that the children feel a little bit more comfortable. Of course, it doesn't really necessarily apply to the adults. So it really depends on where exactly your tumor is located. It could be a long incision, top of the head, can be at the side, can be the back. Sometimes, if it's a surgery, it's just a biopsy or needs a shunt at the same time, you may just have a few small wounds. If the surgery is closer to the base of the neck, of the skull, and includes part of the neck, you may need to wear a collar for a short period of time. So some expectations. Like I said before, this is a broad topic. So I would say that the doctor-patient communication from the beginning, even to the end, is extremely important, because side effects will vary patient to patient. We try to make our treatments, not just myself, but for other doctors as well, as individualized and as personal as possible. So the types of surgeries we encounter in neurosurgery could be something as simple as a biopsy versus what we call a subtotal resection, whereby not 100% or not all of the tumor is taken out for various reasons. Could be because of safety, the structures are too close to something that is essential, like an important artery or a nerve. Or if we can, in some circumstances, we want to try to achieve a gross total resection, which means that the neurosurgeon will do his or her best to take out everything in the same setting as safely as possible. But in general, you may hear the term maximal safe resection, which is usually what we try to achieve as much as possible for a brain tumor. So the expected side effects is really located to where, it's really due to where the brain tumor is located, and to understand how we approach the tumor and what to expect after the surgery, and some possible side effects and possible brain injuries or complications may really have is really related to where exactly the brain tumor is found. So there are many, many types of brain tumors, not just in children, but in adults as well. And these are just some very vague, just very general examples. So like I said, as you can see from this cartoon, is that different tumors can be relocated at different sites. So that entails different expectations and different side effects after the surgery and during the surgery as well. So it's important for the doctors and the patients to have a thorough discussion on what to expect. Some of the symptoms may be experienced by the patients before the surgery already, and the aim of the surgery could simply be to either improve those symptoms or to prevent those symptoms from possibly getting worse or causing structures around the tumor that can cause some of the side effects. So immediately after the surgery, most of the time we tell the patients that there are some side effects that are non-surgery related, and this could be, as I can see from my emo icon, it could be nausea, could be vomiting, could be pain, could be lethargy. So some of these are actually related to the anesthesia itself, and most of it is usually transient. And we usually tell patients that these usually go away after the anesthesia drugs have been washed out of the body. Some other non-surgical related, as in not actually related to the cutting part of the neurosurgery itself, could be that sometimes if the patient is lying too long on a certain part of the body, you may develop some broken skin or pressure sores. But nowadays, I would like to point out that this is extremely uncommon, because we take a lot of effort to make sure that the patients are well padded and protected before and during and after the surgery as well. And some of the complications could be related to the tubes that are inserted that are necessary to monitor the patient during the surgery itself, before and after. So for example, a urinary catheter is important if patients are having especially for patients who are having surgery related to the pituitary gland, that we want to make sure that we know how much urine is coming out or how much fluids are going in. IA line stands for intra-arterial lines. That could be related to making sure your blood pressure is well monitored during surgery. So other things to transfuse you during the surgery include an IV intravenous cannula or even a central venous catheter. So some of the side effects may not necessarily be related to the neurosurgical process itself. But however, directly related to neurosurgery, there are many, I usually counsel my patients to let them know that there are many side effects that could possibly happen. But like I said, before and during surgery, we'll make sure that they are prevented from happening. So I've sort of divided them into a few points, and these are the usual complications I would counsel my patients before surgery. So for example, during surgery, if the patient is old enough to have the head fixed or in a fixation, it could make sure that let them know that there will be pins holding the head completely still, so that any delicate movement to get to the tumor will not damage a normal part of the brain. The wound discomfort before and after, during and after surgery, usually it's temporary. Some of the patients do get some permanent discomfort after that, which I will talk about in a case example a bit later. Things like bleeding, infection, swelling, and seizures, all these could be something very mild and can be treated easily with some medication or just observation. Or sometimes if it's very serious, the patient may need to be brought back to the operating theater. So this is just a general guideline. Of course, we usually tell the patients, although complications are not so high in our modern setting, because we have many modern and effective adjuncts to prevent all these complications from happening. But sometimes if they do happen, we do tell them that there will be a need for them to go back to operating theater, and the hospitalization stay may be a bit longer. So I just have a very quick case example. So this is one of my patients. Mr. SC is a 40-something-year-old gentleman. So when he was referred to me, he already had surgery done twice before by somebody else, and he also had radiation already. So his tumor happened to be in a frontal lobe, and he's really got a background of seizures. So because of the recurrence, it was recommended by his oncologist to have it excised, so that we can see what kind of cells it may have transformed into, or it could be the same previous cells. So after surgery, he actually had immediately a bout of seizures, although he was treated anti-epileptics before and during surgery, and he started to have weakness of one arm and one leg in a week. So looking at this, before surgery, I already told him that these are some of the possible complications. The swelling of the brain after in the area after the tumor was taken out was the reason why he started having some weakness on one side. But once the swelling settled, he was able to get back to sitting up and walking again. So he was doing quite well. He went to the rehabilitation ward. Subsequently, I was called one day to be informed that he started having this unilateral facial swelling on one side of the face for a period of time, but otherwise he was still quite well walking around, and the wound actually was clean. So after examining him, and he was quite well, we managed this conservatively by asking him to sleep his head up and wrapping his head with a bandage for about a week. So this is just an example. I masked out to protect his privacy. So if you look at the blue arrow, so this was where the swelling was directly next to the wound. And after sitting him up, getting him to keep head up for about a week or so, the swelling actually went down. I don't actually have a picture of him, the latest one that I've seen him. So essentially, the swelling had essentially settled. So these are things that happen after surgery and can be sort of immediate or after. A second example that I would like to talk about is another patient of mine. So she's in her 60s, a very nice lady. So she had this tumor that was located in the occipital lobe. And the reason why it was referred is because her eye doctor noticed that she was having she's beginning to see a smaller and smaller visual field. So after surgery, there was no issues and she went home. But about 3 weeks after, she kept telling me that the wound, although not particularly painful, had a sort of funny feeling in it. And at that point in time, we already have done an MRI which actually showed that there was no tumor left and the wound had healed completely. The sutures were all taken out and actually her visual symptoms actually improved. But she was obviously worried about the funny feeling in her wound, and she kept thinking that it was related to the tumor. But what she actually had was what we call a neuralgia. So essentially, this was where the tumor was approached, and because to get to the tumor, we had to sever a couple of subcutaneous, which is superficial branches of the occipital nerve that supplies the sensation to the scalp. So in this case, the reason why she started having some numbness was because when the wound recovered, the nerves didn't actually recover that well. So she was stuck with this funny feeling. But luckily, this is a benign condition and it could be managed conservatively with some medication. And she was reassured that it wasn't because the tumor had come back. And this is just another example of the location of the tumor and the way that the neurosurgeons had to actually approach the tumor. So I'm just going to give some general information and summarize some aspects of my talk. So like I said, this is a very broad topic, and we know that the brain is an extremely complex structure with many important functions. And sometimes these symptoms that happen before and after surgery is likely and most could be related to the location of the tumor. Most of the time, the side effects of surgery, like in a couple of the examples that I've shown, can be very mild or can be serious. If it's serious enough, we may need to prolong the hospitalization stay and make sure that the patients do recover, and also to see whether or not they need to go in again for a second surgery to get rid of the complication or the side effect. But I like to say that the majority of these side effects, they usually recover. It's just that the timing of the recovery really depends on how serious the side effect can be. I think most importantly, the rapport between the doctor and the patients needs to be really good, and all details of surgery really need to be discussed for can be through many consults, or even at different times, to make sure that the patients and the doctors really understand each other's expectations, which is why actually communication really is the key to this. Yeah. So I've given an extremely short and general talk, but thank you for listening. I'm happy to take some questions if needed. Yeah.
All right. Thank you, Dr. Sharon Low, for sharing about non-surgery related as well as surgery related side effects. So the floor is now open to the audience. Are there questions that you have? You can put it in the chat, or you can also unmute yourself and ask the question. All right, so far it looks like no questions coming yet, so that's good. They're probably saving the questions for later on when we have the panel. So we can invite Dr. Lin right now to prepare for his presentation about the side effects that can or may happen from chemotherapy.
So hi everyone. I'd like to thank Melissa as well as Dr. David for inviting me to speak today. Actually very delighted to be here and to be sharing about chemotherapy related adverse effects. So I'm Xuling, I'm from neurology, and I do neuro-oncology at National Neuroscience Institute. Because of the time frame that we have, about 10 to 15 minutes, I've actually focus my talk on very broad general side effects that we commonly have for patients who undergo chemotherapy. And just to cover one or two chemotherapies that are commonly given for adult patients with malignant brain tumors. I don't think we can go through all the different specific chemotherapy side effects. Oops, let me see how I can go to the next. So as mentioned, I would categorize into general adverse effects and specifically targeting fatigue as well as cognitive impairment. What has been sort of broadly mentioned about Chemobrain, some of you may have heard of it, and drug-specific adverse effects such as those in temozolomide as well as Avastin, the two common drugs that we use for adult patients with malignant brain tumors. So I'll broadly cover them and also talk about some of the strategies that you as a patient can use to mitigate some of the side effects. So fatigue. We do know from studies that fatigue is actually very prevalent in patients with primary brain tumors. The most common among the adult populations is glioma. So with patients with high-grade glioma, it's actually up to 96% in terms of studies. And another study looking at both low-grade and high-grade gliomas is up to 42%. So we see the prevalence is actually really quite common. The duration, some people would think that it's only for a very short period after surgery, after chemotherapy, or during the radiation therapy, but it has been shown in studies that it can actually last for quite long with different contributing factors, which I'll talk about. So fatigue, if we think about it, we can actually divide it into two big categories. One, primary fatigue, and secondary fatigue. For primary fatigue, we are actually talking about the fatigue that we have directly related to brain tumor and the treatment. And it's actually really because and not specific to chemotherapy here, whether it's surgery, chemotherapy, or radiation therapy, it has resulted in centrally mediated process being damaged, such as the neuronal damage in the brain itself, due to inflammation after radiation therapy or after surgery, and sometimes demyelination or axonal loss. So demyelination axons are actually part of the nerves in the brain itself, and occasionally in the damage, it can also cause this demyelination and axonal loss. Secondary fatigue actually means fatigue that are not directly due to the brain tumor or the treatment, but because of secondary causes, it causes patients to feel fatigue. And these are contributed by psychological factors like anxiety, depression, and co-occurring symptoms like if patients have sleep disturbances, which is not uncommon, pain symptoms. If there's a lot of pain that is not well controlled with medications, patients can feel very fatigued as well. Other causes includes comorbid conditions such as hormonal dysfunction, like thyroid dysfunction. If there's concomitant infections that are ongoing, malnutrition, and often for patients with brain tumors, they may be on anti-seizure medications, the anti-epileptic medications, and some of this have a bit of sedative effects, and that can also contribute to fatigue. Of course, as I'm supposed to be covering, chemotherapy also will contribute to fatigue. So at this point, while my focus is supposed to be on chemotherapy, I think I'm covering one of the very common side effects that we do see in patients throughout the course of their treatment. Some strategies that we commonly advise patients in terms of how they can combat fatigue would include: one, identify and manage treatable causes of secondary fatigue. And this includes identifying any mood issues, whether it's anxiety or depression. So talk to your doctors about it. If you feel very fatigued, that's where the doctors will step in and sort of screen you for possible mood issues that are not uncommon when patients do have a diagnosis of tumors. Treat any pain symptoms. So if you do have pain, do report it to your doctors, and they would actually try to mitigate the pain for you. Manage rest and sleep. Do some exercises and really maintain a good diet and nutrition. These are all, sounds very little, but they are very important parts in trying to combat fatigue for patients. Treat comorbid conditions. This is where your doctors will come in to, if you have very significant fatigue that seems to be out of proportion to what they see in other patients with similar conditions like yourself and undergoing similar treatment, they may suggest to do additional blood tests to exclude hormonal dysfunctions or infections, especially if you have fever or other symptoms of infection. And as far as possible, and not always possible, avoid sedating agents. Sometimes in certain occasions, some seizure medications can be switched to something less sedative as well. So it is really important to be upfront with your doctors that you're experiencing a lot of fatigue and see how we can manage it. There are a lot of trials that have gone on in terms of looking at medications or non-pharmacological treatment for fatigue. Unfortunately, none of them have really shown very conclusive power to demonstrate that they are very useful for fatigue. So at this point in time, there's still insufficient evidence from all the clinical trials put together to draw a reliable conclusion that it's effective. This includes medications called the stimulants like modafinil, methylphenidate, and there are some centers that also look at cognitive rehab therapy. So it's not medications, it's non-pharmacological methods to try and combat fatigue. Some have demonstrated, some studies actually demonstrated good results, but they're typically in a very small number of patients. And that's why at this point in time, it still seems like an insufficient amount of evidence, but it is still worthwhile discussing with your doctors whether you may benefit from either the drugs or the non-pharmacological therapies. So at NNI, we actually do give out some pamphlets for patients. We actually just came up with brochures with regards to how we can prevent and cope with fatigue. I wouldn't go through all of them. I think I've talked about some of them, including getting enough rest, sleeping well. One thing to note, while you might be fatigued in the daytime, try to reduce the amount of time you spend sleeping your naps to less than an hour so that you don't get this reverse in the night and awake, the regularity, and spend time at night awake and then daytime sleeping. That will be actually worse for the overall fatigue for yourself. So I'll move on from fatigue to talk about what some of you may have heard about Chemobrain. So the concept of Chemobrain is actually chemotherapy-related cognitive impairment, and it's actually studied more extensively in patients with systemic cancers. In other words, patients who have tumors arising from other parts of the body. Very commonly, this is studied actually in patients with breast cancers. Part of the reason is that commonly we are unable to distinguish the cognitive impairment from chemotherapy, from the brain tumor, surgery, and radiation therapy for patients with brain tumors. So that makes it a bit harder to define what really is the cognitive impairment that is caused by chemotherapy alone. However, I think if we were to just look at these studies on Chemobrain that I've pointed out that are done in mainly in non-brain tumor patients, the main cognitive domains that are affected is short-term and working memory. So working memory is sort of defined as the limited capacity that's stored for retaining information for a brief period. So while performing some mental operations on that information. So if I put that in daily practice, let's say you're a mother at home, then and you're looking at a recipe and you want to cook, that actually requires you to store that memory of what the recipe is and to perform that steps one by one. That is the working memory. So that may be affected by chemotherapy. Executive functions, it's actually, which can be impaired with chemotherapy as well. That's with regards to planning. So let's say you are thinking of planning for a birthday party for your child over Christmas, then that requires a lot of planning with regards to finding the location, a right venue, the people that you want to invite, and so on and so forth. So that requires you to think through various parts and plan. That's executive function. And processing speed, I think we all take it for granted that when all your cognitive domains are working, that we can function properly, but there is a need for the brain, for different parts of the brain to speak to one another, and that speaking to one to another can actually be affected such that the whole speed slows. So the processing speed can sometimes be slowed down. In other words, something that you take, let's say just doing mathematics, you may last time do it instantaneously. When the cognition is slightly impaired from chemotherapy, that may take a longer time for you to process it. So what we do know that is in general and in studies, there is a discrepancy between the reported symptoms by patients and what the doctors can actually test. Sometimes we think it's influenced by psychological factors, but in reality, there is also limitations to what we can test in terms of the cognitive testing that we can do in the clinics, because there are patients who are very well educated, and some of these cognitive tests may not pick up very subtle symptoms or cognitive impairment, but that doesn't mean that it's not there. The duration of it, we typically do say that the Chemobrain, the cognitive impairment that is resulted from chemotherapy, typically should improve within 9 to 12 months after you have stopped chemotherapy. But there are a small group of patients that continue to have long-term but stable effects. So what are some strategies that we can do to combat Chemobrain? In very broad ways, engage in exercises. I think it's important for us to recognize that it's not really the mental exercises like playing mahjong. You can do that and it may be helpful, but doing engaging exercises have been shown both aerobic and more recently there's some studies demonstrating that resistance and strength training actually does help. Managing sleep and rest, as well as your nutrition and diet, sort of similar to how you can combat fatigue that comes together. Identifying and treating anxiety and depression. We do know that when someone has very low mood, depressed or anxious, it actually affects the brain attention span for them to actually focus on the task in front of them. And that actually sometimes results in the perceived cognitive impairment. So treating the anxiety and depression actually overall does help. And finally, it's actually important to report to your doctor, because sometimes when, again, it is out of proportion to what we expect for your condition, we would actually screen for thyroid dysfunction and vitamin B12 and folate deficiencies, because all these are reversible causes of cognitive impairment, such as if you have vitamin B12 deficiency, it's quite easy. We just need to prescribe you oral medications for supplements. Similar to fatigue, there's actually no evidence to support the use of pharmacological interventions at this point. There are a lot of different trials using similar modafinil and so on in randomized controlled trials, but none of them has really been shown to be that effective. I think Dr. Bala might be speaking a bit later about some drugs that may be used for post-radiation therapy, but in the setting of chemotherapy, no specific medication. So really try the strategies that I've shared earlier on. I'll move on away from the more general adverse effects that we see with chemotherapy to two specific drugs, what I call the drug-specific side effects. So one of the common drugs that we do administer, especially for patients with, I pointed out the malignant brain tumors, is temozolomide. It's the standard of care for the patients. It is associated with fatigue, which we've shared earlier on, nausea, constipation, liver dysfunction, and hematological dysfunction like low white blood cells. White blood cells is the cells that are in our body to help us fight infections. It's part of the immunity. And platelet is the cell counts in our body that helps us clot. Part of the reason why there could be hematological dysfunction, not just for temozolomide, but a lot of the traditional chemotherapies, is that they work on the cells that are sort of replicating and proliferating very fast. So that's how tumors are. They grow really fast, faster than the normal cells. And that's why the chemotherapies target these cells. But at the same time, the bone marrow, which is where it generates the white blood cells and platelets and all your cells, that's also a very fast turnover area. And that's a common area to be affected. So what are some strategies that we do advise patients for the common side effects, again, not just in temozolomide, such as nausea and constipation? Without going through in details, I think it's important in terms of prevention, if the doctors have prescribed you anti-nausea medications for your specific chemotherapy, take it, because it really does help to reduce the risk of the chemotherapy causing nausea, vomiting. We in general, from an oncology standpoint, do classify the chemotherapy into unlikely to cause nausea, vomiting, mildly able to, moderately, and very likely to cause it. So depending on that, that sort of category of the medications that you may be receiving, it will determine the amount of anti-nausea medications that needs to be given to the patient prior to the chemotherapy. So if your doctors do prescribe it, do remember to take it at the right time before your chemotherapy. I think the other one that I like to stress is that if patients do feel nausea, we often do advise to take small frequent meals throughout the day instead of trying to achieve what we typically do, 3 big meals a day. So instead of 3 big meals, cut them into small meals, maybe up to 5-6 times a day. That's usually much more tolerable, and at least you can get the full amount of calories that you need per day to maintain your nutrition and calories. The other thing to highlight is to avoid lying flat right after you have lied down, right after you have eaten. That actually prevents reflux and worsen the nausea, vomiting. So I won't go through the rest, but some the other common side effects with regards to chemotherapy, specifically temozolomide, is constipation. Common strategies: drinking plenty of water, increasing fiber intake, keeping an active lifestyle. The less active you are, the more likely there is stasis and the less mobility of your gut. So I've gone through regards to temozolomide, and that sort of ties in a bit with some of the traditional old chemotherapies. Some of the newer therapies include Avastin. It's not a classical old traditional treatment. Avastin itself is an antibody that actually works on a vessel receptor of tumor cells. But because it works on blood vessels, a lot of the side effects actually is related to that concept, where it results in high blood pressure. It can result in clotting of the blood vessels in elsewhere of the body. It can result in bleeding. So it's sort of thinking about it in terms of the vessel problems, and even the protein in the urine is because of the vessel changes in the kidneys, and poor wound healing because the vessels are affected. So all that sounds relatively concerning, but in general, the risk of them happening is relatively low, but the doctors would counsel with regards to the possible side effects or adverse events that can happen with these drugs. But at the end of it, I think while today's talk is focused a lot about toxicity and side effects, I think it's actually important to recognize that as doctors, we do try our best to mitigate the risk of the side effects. And at the end of it, it's really balancing the risk and the needs. And we would, as far as possible, mitigate the risk, but I think it's important to recognize that for controlling the tumors or treating or curing the tumors in certain circumstances, certain treatments would still need to be undergo, and it's important to, as what Dr. Sharon mentioned, have a good rapport with your doctors, report to them about symptoms, and they will be able to identify, investigate, if necessary, additional reasons for why you are experiencing some of the side effects that you are. And so with that, I will end my talk, and I thank you for your attention. I'll be happy to take any questions as well.
Okay, so we're open for questions. Thank you very much, Xuling, for sharing your talk about Chemobrain and also the effects that are very common due to the common drugs that we take for brain cancer patients. So any questions from the audience? Yeah. So I think, a few of us could be suffering from, carbo brain, because we're having this talk right after lunch. So there's lots of sugar. And maybe that's why, everyone is less active with regards to questions. So the chat box is open all the same. And if you happen to recover from your carbo overload. You can start putting it in the chat as we go along. And now we invite Dr. Bala from NUH to be sharing his presentation about possible side effects arising from radiotherapy.
Thanks, Melissa, and thanks, Dr. David Low, for the invitation, as well as BTSS. And thanks to all of you for joining us on a Saturday afternoon. You can hear me, right? You can see my slides.
Yep. We can hear you.
Okay, yeah. So I've been asked to talk about the radiotherapy aspect of treatment, and this is unfortunately causes a lot of fear for patients. Radiation itself instills fear in them, and a lot of them shun radiation. But hopefully with today's talk, I can dispel some of that fear and answer some of your questions. So this is, as Sharon mentioned, quite a broad topic, so we can't possibly be exhaustive, but just want to talk about some broad principles. We'll look at the role of brain radiotherapy, and we'll also look at some of the modalities that we use to treat brain tumors, talk about some of the potential side effects that patients can experience, and clearly some mitigation strategies are also being touched on. So whenever we talk about brain tumors, radiation therapy doesn't exist in isolation. It's generally a multimodal approach that we use for most tumors. Surgery can remove the tumor, but sometimes there could be remnant tumor cells left behind, or if there's in a particular part of the brain where surgery cannot clear, radiation comes in as a form of local treatment to tackle that remaining tumor. And there have been multiple guidelines in clinical trials which support the use of radiation therapy in a variety of brain tumors. Just to summarize, radiotherapy is the use of beams which deposit energy into the tissue, and this energy actually causes damage to the DNA of the tumor and thereby killing it off and reducing the risk of the recurrence. When we give radiation therapy, we are trying to be as precise as possible, targeting the cancer and the adjacent at-risk areas. But because of the way the radiation beam behaves, there will be a bit of entrance and exit dose, which is unavoidable. And this is what sometimes causes side effects in patients. Talking about radiotherapy technology, so what we commonly have in most of the hospitals is a linear accelerator. So that is this machine that produces the radiation beams, and it comes in from multiple directions. And where it intersects is where the high dose area happens. And this machine can actually rotate around the patient and also try to be as conformal or as accurate as possible. Another type of radiation is what we call radiosurgery, and that is sometimes given by this machine called a gamma knife machine. And this is typically for tumors which are small and very well defined. Generally, if the tumor is large and infiltrative, you will need to do this other treatment called external beam radiation therapy. Most of you may have heard about this newer type of treatment which is going to come to our shores in the next year, which is called proton therapy. This is a different type of radiation machine, and the main difference, as summarized by this newspaper article, is that where the tumor is, the effect is the same, but what the main difference is that there's minimal exit dose when it comes to proton therapy. Therefore, the intermediate doses to the other sites of the brain can be reduced by using proton therapy. Common to all of these technologies or therapies, we do need to ensure adequate immobilization for the patient, which means they have to be still and fixed for the duration of the treatment. We do need accurate imaging. Once imaging is obtained, we do need to delineate where the tumor is. And there is a lot of technical work that goes on in terms of radiation planning, as well as in image-guided delivery of the treatment. From this picture, you can see that the high dose is concentrated to where the brain tumor is in red, but the intermediate doses are present as well, as you see in green and in blue. There are parts of the brain which will be completely avoided by the radiation, but the adjacent areas, it's hard to avoid them entirely. And if you ask any radiation oncologist, this is a common principle that we follow. We do expect a dose response in tumors. Where we give a higher dose, we expect a better control. But unfortunately, that dose response is also seen in normal tissues, where you do get side effects as the dose increases. And where we want to be is actually this curve on the green. We want a high rate of tumor control and a low rate of complications. And this is what we call is complication-free cure. Putting things in perspective, radiation doses vary, and gray, GY, is a unit of radiation. So the amount of radiation that we give can vary from patient to patient. Typically, it can go as low as 20 units or 20 gray to as high as 60 gray when we are trying to tackle very aggressive brain cancers. And what we need to actually know is that this is the numerator, how many units we are giving, but the amount of sessions we divide it over actually has some impact of the effect of the radiation. For example, in patients with being treated with gamma knife radiosurgery, it's a small target. We actually give 20 gray in 1 unit. It might seem like it's a low dose, but because it's given in 1 session, the equivalent dose is actually pretty high. Compared to a patient who's getting 20 gray in 5 sessions, which is a typical palliative dose that we use, this is a very gentle treatment where we don't expect any serious side effects with this kind of doses. The other thing to note is that there's also a volume effect. The larger area of brain that we treat, we do expect more side effects. Small volumes of brain tissue can be treated pretty safely to higher doses, but when the tumor size becomes larger and larger, we will need to take into account the volume of brain we are treating. And if you all are wondering why there's a picture of this RAM here, please feel free to message me and I'll explain where this ties in with this entire explanation. So coming to side effects, as Sharon and Xuling also mentioned, we generally tend to divide it into 2 big categories, short-term and long-term. Short-term side effects typically occur during the duration of radiotherapy or within a couple of months after. As you can see on this slide, these are relatively common, but generally they are mild, and the good news is that most of these recover. Longer-term side effects may occur months or years after treatment. Thankfully, they are uncommon, and sometimes if they occur, the recovery may not be a complete recovery if they occur. And side effects, you can't take them in isolation. It's usually multifactorial why these side effects happen. You can't just say it's one treatment that's causing the side effect. We do have to consider all the other possible contributing factors which can lead to these side effects. And generally, we can divide them into patient factors, treatment factors, and disease factors. For example, in patient factors, we do need to consider what is the patient's age, what are the comorbidities, meaning what other medical conditions do they have which may predispose to them developing certain side effects. For example, if they have uncontrolled diabetes or if they have a connective tissue disorder like scleroderma or SLE, perhaps sometimes they do get a bit more radiation-related side effects. In terms of treatment factors, at least from the radiation perspective, the things to note are that we need to consider what is the dose of radiation we are giving. Is it radiotherapy alone, or are we combining this with chemotherapy? And generally, for combination treatment, we do expect more side effects compared to a single treatment alone. Other factors to note is how many sessions do we give this in? And clearly, the most important thing is where is the tumor, because that is what influences the kind of side effects the patient may experience. As you saw in the pictures earlier, the dose is actually quite related to actually where the tumor is in the surrounding areas, and the side effects are also linked to where the dose is being delivered to. Disease factors, so why are we giving the reason we're giving the patient's treatment? So what is the underlying diagnosis? And this may also influence the side effects the patients may experience, which is linked to what is their prognosis or overall survival. Sometimes patients who have a long survival, who are being treated for benign conditions, they have a higher chance of experiencing these longer term side effects by the sheer fact that they can actually live longer than patients with, for example, brain metastasis, where the prognosis may only be less than a year in some patients, and the chance of getting these long-term side effects is not common. So incidentally, we actually wrote a paper looking at radiotherapy to the brain. So this is radiotherapy to the brain is actually not a new treatment. It's been in clinical use for more than 120 years. But the main thing that has changed is how this radiation is delivered. And as more studies are being done, we are also gathering more evidence of what are the potential side effects that patients experience. So I won't go through this, but this is an open access paper and it's free to download. But in essence, what we talked about in this paper is what are the mechanisms of radiation-induced brain injury. So one of the main factors is radiation may cause blood vessels or capillaries to actually become more narrow, affecting the blood flow to certain parts of the brain, leading to hypoxic, reduction in oxygen to certain parts of the brain, which may lead to damage to the brain tissue itself. Other methods of how radiation side effects occur is that some of the supporting cells, such as the oligodendrocytes or astrocytes, may also be affected in their function, leading to things like demyelination, which was mentioned previously. And lastly, there are also certain structures within the brain, such as the hippocampus, which are involved in functions such as memory and decision making, which can also be affected if a high dose of radiation is delivered to the area. So this is quite a general list. It may not apply to all patients. Like I said, it depends on the dose and the location of the treatment. But if you look at what are the short-term side effects, commonly patients may experience fatigue, as was touched on before. They may experience headaches due to some swelling which may occur either from the tumor itself or from the treatment that the patients are undergoing. Hair loss is one of the common things that is unavoidable actually. When we are getting treatment to the brain, it has to pass through our scalp, and our scalp, our hair follicles are sensitive to radiation, radiotherapy. And generally, patients do get patchy hair loss, as you can see in this picture here. And sometimes they also get skin reaction. So a common question that usually comes our way from patients is my skin going to get burnt from the radiation? So that may have been the case with older radiotherapy machines where a high dose was deposited to the skin before it got to the tumor. But thankfully, with modern technology, higher energy radiation machines, actually the skin is being spared while the radiation is being delivered to the tumor. So we do not see skin burns in patients, but they do get mild skin reaction, as you can see in this patient here. Hair loss is also quite related to the dose of radiation therapy. And patients always ask, is my hair going to grow back? So thankfully, hair does grow back, but it may take a few months. But the quality of the hair may be different post-radiation. It might be slightly thinner or slightly more wispy compared to your natural hair. And generally, younger patients do have a higher chance of recovery compared to older patients when they undergo radiotherapy. The other side effects short-term would be nausea and vomiting. And sometimes patients do experience a change in taste as well. That may be related to sometimes the salivary glands or the tongue getting a little bit of radiation as the beam passes through to certain parts of the brain. And thankfully, this also recovers with time. In the medium term, that means probably a month or 2 months after radiation, some patients may feel slightly more fatigued or sleepy. And this is related to demyelination, but thankfully this is it recovers by itself, and sometimes it requires a short course of steroids. In terms of the longer term side effects, like I mentioned here, it's uncommon, but we do discuss this with patients just to make sure that they are also in the know of what are the potential complications which may happen. So in the poll, this was highlighted that changes in memory and concentration is one of the key factors that patients actually put value on. This may happen with radiation, and I'll touch on how we can actually mitigate some of these changes with modern technology and some medications. The lens is actually quite sensitive to radiation. So if the lens actually gets radiotherapy beams passing through, patients may develop cataracts down the road. But thankfully now cataracts are pretty easy to fix. So we don't put too much emphasis on the side effect, because even if it happens, replacing it is pretty easy and patient can usually get a full recovery of that issue. Depending on the location of the tumor, sometimes patients do get decrease in hearing. And also because of the blood vessel narrowing, they can get sometimes transient stroke-like symptoms. One of the issues that we have when treating patients with brain tumors or brain metastasis is something called radionecrosis. This is actually when all the tumor dies, but tumor is not active, But as a result of the treatment, sometimes you get a bit of scarring in the surrounding brain, which can result in swelling and sometimes symptoms. Diagnosing this can be difficult, but there are some treatment methods that have been recently used, including Avastin. If the radiation beam is near the pituitary gland, patients can get hormonal changes, and we do talk about infertility as well. But if it's due infertility to hormonal changes, this can sometimes be corrected with pills. And one of the common or important things that we do talk to patients, especially patients who are in the pediatric age group with brain cancers, is the treatment that we are giving does help to control the tumor and help them have a longer survival. But unfortunately, while doing that, there is a risk that the treatment that we're giving can induce a different type of a cancer in that region, which may manifest 10, 15 years later. The younger they are, the chances of this happening is higher. For older patients, the risk of this happening, of getting a secondary malignancy, is actually quite low. So I just wanted to touch on some mitigation strategies that we have. So for hair loss, like I said, we're using higher energy beams to avoid the scalp. We can also control the radiation beam to avoid the actual scalp itself. And sometimes when it happens, patients do use wigs until the hair regrows, then they can do away with the wigs. For nausea and vomiting, I think Sharon shared a very nice list of things that can be done, including medications as well as some dietary modifications. For patients who develop somnolence post-radiation, we do consider short course of steroids in some patients. I put this picture up because some patients do use it. This is the acupressure band, which sometimes can cause nausea, but I must say there is no strong evidence to say that this actually reduces nausea. In terms of the longer term complications, some of the mitigation strategies that we use is recently there has been some evidence to suggest that certain medications which was previously used in patients with dementia can actually improve the mental function of patients who have undergone radiation. So this is called Memantine, and patients have to be on this for about 6 months. We do use it we are increasingly using it for patients, and it's pretty well tolerated. Another mitigation strategy is that you heard about the hippocampus, so we can actually reduce the dose to the hippocampus to reduce the impact of the memory and cognition post-radiation. In terms of radiation necrosis, we do place a lot of emphasis on radiotherapy planning and conformal radiation therapy. For hormonal changes, screening may be important, as well as a replacement if the hormone levels drop. For secondary malignancy, we do consider proton beam therapy for young patients who are at a higher chance of getting secondary malignancies, because, as I mentioned earlier, proton beam therapy does reduce the low doses that get splashed to some parts of the brain with the current technology that we have. Just want to touch on hippocampal avoidance RT. So hippocampus actually means seahorse from Latin, and this is a structure within the temporal lobe, which is actually involved in short-term and long-term memories and spatial navigation. So some studies have suggested that actually if we try to reduce the dose of hippocampus, patients actually have less neurocognitive deficits. And this is enabled by modern technology, which can actually modulate or reduce the dose to just the hippocampus, whereas the dose to the other parts of the brain can be quite uniform. And touch on the proton therapy as well. So this is a proton therapy plan for a patient with a low-grade glioma. So patients with low-grade gliomas are expected to have a longer survival in the terms of years. So it might be quite important to actually put some emphasis on their quality of life and the neurocognitive deficits which may occur with IMRT. IMRT is what we usually offer for our patients currently. So what you can see is the intermediate and low doses is reduced with proton therapy, but the high dose area is still the same. So the side effects that occur in the high dose area will not be different between the two. But in the other parts of the brain, because of the physical property of the proton therapy beam, this can be mitigated. So I think it's quite important to highlight that sometimes patients are quite overwhelmed when they get the diagnosis and all the information is flying at them regarding different treatments, and they may not process the things that we're actually bringing across to them. So there are some good resources that patients can go to read up more about their condition as well as their treatments. And it's important to go to regulated websites, because sometimes if you just go to forums, you hear things that may not be that true, and that may actually influence your decision making. I just want to end off with this slide. I think radiotherapy has been and will be an important pillar in neuro-oncology. We are focusing on the softer endpoints besides tumor control, such as quality of life and neurocognition. Patient selection is clearly important when we select the treatment for the patient. And there are currently a lot of ongoing trials which are focusing on how we can improve the delivery of RT and mitigate some of the side effects. In fact, we're going to start one at NUH where we're actually looking at a brain app. It's like a brain gym to train the patients as they undergo radiation, so that we can actually reduce the neurocognitive deficits that they experience. And like Sharon and Xuling said, it's important to talk to your doctors and have a good rapport with them to talk about the risks and benefits of the treatment. Yeah, with that, I'd like to end.
Thank you, Dr. Bala, for this very interesting talk. And wow, I thought that the hippocampus really looked like a seahorse. Something new that I learned today. Okay, so now let's open up for a time of discussion with our panels. And if you have a question for Dr. Bala, please feel free to post your question. Otherwise, he promised that if we send him a chat, he will explain to us this thing about the RAM. What is this RAM thing about, that we saw? Like an injection, in the rear of the RAM.
Yeah. So the concept of fractionating RT, that means splitting up into different sessions, actually came from farmers in France. So they used to sterilize their RAM by using radiation therapy. And if they gave the radiation therapy in a single session, they actually found that these RAM actually developed a lot of scrotal skin reaction.
Okay.
Before they could be sterilized. Okay. So by actually splitting up the dose into smaller packets or smaller sessions, they could achieve the same objective of sterilizing the RAMs without having the skin reaction.
Oh, okay.
And that actually translated into clinical practice, and that's what we do in the current day.
Okay, all right. Wow, that's really interesting to know. Okay, thank you for the origin of splitting dose radio doses into smaller doses. Okay, there's a question about how many times can a patient undergo radiotherapy, or what is the maximum dose that any patient can take?
Yeah. So the first chance that we have is the best chance. Whenever we have a recurrence, it's always quite difficult to deal with. The reason being is that our body and our brain remembers that we have undergone radiation therapy before, and the recovery of the tissues in that, or brain cells or tissues in that area, may not be complete after the first course of radiation therapy. Mm-hmm. So to answer that question, I think it depends on a lot of factors. Patients can go and repeat radiation, but the risks and side effects are usually higher with the second course. And generally, we need to reduce the dose that we can give for the second course of radiation therapy.
All right. Okay. And there is another question.
Can I ask a question, Derek? Or what?
Oh yes, I have a question from Colin Chia first. Are you Colin?
No, I'm not. I will wait.
Okay, so let me ask Colin's question first, and then you will be next. All right? Okay. Colin's Chia's question in the chat is that, could we say that memory loss or decreased concentration is a general side effect in brain tumor patients, be it radio or chemo or neurosurgery? And would general health supplements be beneficial? So any doctor, feel free to take this question and to add on. Okay,
I
Xuling?
can take the question. So
Mm.
I think in general, memory loss or decreased concentration, as asked by Colin, it is one of those side effects that we see in brain tumor patients. In reality, most brain tumor patients, if it's a malignant brain tumor, they do undergo surgery, radiation therapy, and chemotherapy. So it is sometimes difficult to tease out how much of the cognitive impairment or the decreased concentration is from which factor. But individually, after surgery, in terms of pre-surgery and post-surgery cognitive tools that are done for patients, and similarly for chemotherapy, pre and post-chemotherapy, and then for radiation, pre and post, all of them have been shown in various studies to contribute to memory loss or decreased concentration. A lot of times, as I think all three speakers have highlighted, it's short term, it's temporary. It's also multifactorial. It's not always a direct injury, but there are other contributing factors, including like fatigue, lack of sleep in patients, mood issues. All those do contribute to your ability to pay attention to tasks in front of you and what seems to be decreased concentration as well. So putting it all together to answer his question, we can think of it as very broadly, yes, a side effect that is potential in any of the treatment options, and not forgetting brain tumor itself also, depending on which area of the brain and how big it is, can also cause cognitive impairment. I think the second question, the general health supplements, I mean, from my end, in general, we don't have specific health supplements that we would specifically recommend patients to take. But there are situations where some patients, because their nutrition is affected by loss of appetite, nausea, vomiting, and they may have certain deficiencies in their body that, for example, vitamin B deficiencies, then in those situations, they may have symptoms that the doctors might end up doing additional blood tests to demonstrate the reduce or the deficiencies. Then in those settings, there's a need to supplement according to the deficiencies. But very broadly, there isn't really health supplements that are proven to be effective that we would recommend.
All right. Okay, thank you, Xuling. Sharon wanted to say something. Yeah.
I just wanted to say that back to the question on memory and also decreased concentration. Sometimes it really depends on the location of the original tumor as well. So if your tumor is located in an area where, for example, the frontal temporal lobes, and unfortunately that had to be removed during the course of surgery, yes, that could be probably because of that. But usually, as like I said, we try to preserve important structures as much as possible. Sometimes after a period of neurocognitive rehab, there is some improvement after that. Yeah.
Okay, thank you for sharing that. You know, I was related to the health supplement questions. I remember that I was given a lot of Neuron B because it's supposed to help in the healing of the nerves. And I also wonder whether there's a place for ginkgo supplement to improve memory. So what do you say to that?
I can take that question. So I think the ginkgo for memory, not specifically for brain tumors, but I think in general for dementia, there are some studies that potentially have results that demonstrate there may be benefits from taking ginkgo supplements. The studies are not too conclusive. So even for patients with dementias, we don't on a regular basis recommend ginkgo. The main concern about ginkgo is that it does have, it's associated in some studies with slightly increased risk of bleeding. So from that perspective, it may be helpful to discuss supplements, not just ginkgo, but in very broadly, some supplements that you would want to take. Myself, I don't typically stop patients from taking supplements as long as they are upfront with it and we are able to monitor potential side effects that comes with the supplements. So I think it's still going back to the point of having the rapport with your doctors and being upfront with some of the supplements that you may be intending to take. Going back to ginkgo, yes, you may consider, but do tell your doctors in case there's clash with the
neuron
treatment.
B, vitamin neuron B too.
The neuron bio, yeah, that's actually vitamin B supplements. It's commonly given. There's a lack of evidence of it being actually able to improve cognitive functions for patients. But again, no specific harm unless you take it excessively.
Okay, and I would like to request the audience to, it would be better to type your question in the chat. I think it would be better that way, all right? So let's move on to the next one, which is how old must children be at least for them to qualify for radiotherapy?
So I'll take that.
Okay.
So generally, we try to avoid radiation in young children and pediatrics if it's possible. However, if the case is there and we think the benefit is there, we do discuss the risks and benefits with the parents. In general, most of the protocols and treatments, they try to avoid radiation in kids who are below 3 because that's when the brain is really developing. And sometimes we use other treatments to defer the radiation to a later time when the kid is already a bit older and can undergo this treatment.
Okay, and I was wondering, where would NUH patients do the proton therapy? Since the proton beam therapy would be...
Yeah, it really depends which center starts first. The NCC center is supposed to be a national facility. So I think there are plans for us to collaborate with NCC for patients who require proton therapy. But I think there's also some private centers who may start first. So I think we'll see it as a case-by-case basis.
All right. Okay. So there is another question about a boy who had undergone proton therapy last year, and the eye doctor detected some yellow wool spots in his eyes. And the parent is wondering whether or not this could be a side effect of the proton treatment.
I think if the yellow wool spots are probably exudates, which may be related to what we call retinopathy. So it is a possibility, especially if the tumor was already near the eyeball to start with. So the radiation beam may have had to pass near the eyeball in order to deliver the dose. So sometimes we can see such changes in the eye post-treatment.
I see. And would it recover over time?
Spontaneous recovery, I think the cause may vary from patient to patient, but sometimes patients with slightly more serious side effects of retinopathy, they may require medications to help.
Okay, all right. And in this case, what sort of medications could help this, the eye condition?
Yeah, I think if it's severe, they have tried things like Avastin, but used within the eye to help to reduce those side effects.
I see. Okay, thank you. And there is also a question about, a patient having 2 years of radiotherapy, and she's still experiencing, focus issues, concentrating, for example. And what are some tips or advice that you would give to this patient who is still trying to concentrate and improve in her concentration?
Does anyone want to take that? Oh. Yeah, so I think it can be quite a few factors why she's experiencing that side effect. In terms of what she can do, medications-wise, what I mentioned was actually used during and shortly after. So whether it's licensed to be used such a long period after radiation therapy, I'm not certain. But generally, things like meditation, mindfulness may help. But there's no evidence to support it one way or the other. But general lifestyle factors like exercise may also help to increase the blood flow to the brain and things like that.
Yeah. Okay. And a patient would like to know for brain cancer treatment, it's radiotherapy and chemo given separately. For example, radiotherapy first and then chemo. And under what circumstances are they administered concurrently?
I can take that.
Okay.
So I think it really depends on the type of tumor. So for example, what I was citing earlier on for the most common malignant brain tumors in adults are glioma, the high-grade gliomas. The current standard therapy is giving concurrent radiation therapy and a medication called temozolomide together, followed by temozolomide alone. In what is more common in children for primary brain tumors like medulloblastoma, it's often sequential. It's radiation therapy, then chemotherapy, although there are some trials that are demonstrating use of concurrent as well. So it really depends on the type of tumors and what is considered standard for that type of tumor to be given, whether it's together or sequentially.
Okay, thank you, Xuling. And David, he's just responded to a question on TCM. Perhaps you'd like to summarize that, David.
Yeah, so I mean, there are many different types of TCM medications. I mean, we encounter that when we interact with patients. So it's always best to consult the different doctors that are involved in the treatment, because some TCM medications can have side effects related to interfering with the chemotherapy, or you know, if subsequent surgery may be planned for later on. So, and this would be on a very case-by-case basis. So definitely speak to the doctors involved in the treatment before starting any TCM medications.
Okay, thank you. And you know, I just want to, Lighty, you were saying that let's see. Oh, Peter Quack, he's saying that he will be going for radiotherapy for another 3 weeks, starting in mid-December. You know, our thoughts are with you, and we wish you all the best. You must jayo, okay, Peter? And we have a question as well about how to find out more. He was thinking about how to find out more, something about side effects, and it will last for 1.5 years to 2 years before you die away. It sounds really very sad. And Peter, perhaps, you know, you want to clarify exactly what you like to find out more. Okay. And how long will young patients have to continue with MRI scans after post-treatment? How long do they have to keep up with it? When can
I
they
can
stop?
take, yeah, I can
Yes,
take
Sharon.
this question. So for our pediatric patients, depending on the type of tumor it is, usually we follow them up at least once a year after treatment. Of course, if it's something aggressive or they develop symptoms in between the MRI scans, we do ask them to come back earlier. For some of our very, very stable patients, about 3-4 years after treatment, the MRI scans do not show any recurrence. There is a possibility of discussing with them. Perhaps we can do once every 2 years, but it's a case-to-case basis. But generally, the rule of thumb is at least once a year.
Okay, all right. Right, so it's at least once a year. So are there any more questions? Well, otherwise, yes, there's a question from Alan, and it's about acoustic neuroma, and the patient underwent fractional radiotherapy last year using the Novalis shape beam, 28 sessions. And what is the risk? What is the probability risk, perhaps, of developing a secondary malignancy?
Yeah. Hi, Ellen. So, so the risk of secondary malignancy, it depends on a couple of factors. So primarily, we are mainly interested in the age of the patient when they undergo radiation. The risk of second cancers is especially high in younger patients. For older patients, I think you know, the risk is going to be usually quote less than 1 to 3%, but that's a factor of how long the follow-up is going to be. So the longer we live, the risk may be slightly higher. But generally, the literature suggests that it's actually quite low for your condition to develop a second cancer because of this treatment.
Okay, right. So, okay. So the next question would be, someone mentioned to me about TT Fields treatment. I wonder if you can provide more information on this. I can connect with you if you're interested in TTF. In NUH, at least for one NUH patient, I had worked together with neuro-oncology division to treat a patient with Novocure TTF with a collaboration, through a collaboration with the Hong Kong doctors. So, Lighty, if you would like to find out more, you can connect with BTSS separately on this, and we can do the reference for you. Okay. So any other questions, please put in quickly, because we are at 10 o'clock, 4 o'clock, 4 p.m. mark. And